So, how are episodes of elevated mood managed? The first step is to identify and treat any medical causes and deal with precipitants such as cessation or maintenance drugs, illicit drug use, and stressful life events. We all know and recognize that there are certain medical conditions that are responsible for mania or hypomanic episodes. And I can think about steroids, the hormones, brain tumors, medications, poor compliance, often a function of poor psychoeducation, illicit drug use, substances, alcohol, even prescription medications like the psychostimulants, stressful life events. All these form part of the information gathering that we do as we start to evaluate and look at how we can then manage these patients. Because they come with a variety of causes for either relapses or onset of the illness. The presence of antidepressants, when a person is in an elevated mood, should be reviewed, and those antidepressants withdrawn, like I mentioned earlier. Being on an antidepressant can be viewed as causing harm rather than helping to manage the individual. The efficacy and tolerability of any treatments for past episodes should be reviewed, and current long-term treatment optimized or restarted if it had been stopped. And this is an ongoing process that we do each time a patient comes for review. You want to know, is my medication really working? Is the patient having good control? Or if their moods are elevated, what could be causing it? And is it possible that there is poor compliance? Has the patient stopped the medication? And in general, it's known that antipsychotics will be the first-line treatment for mania, particularly when it's severe, because if you want to bring the episode down quickly, you may not do so with things like lithium and the anticonvulsant antipsychotic agents. You may find yourself having to use strong antipsychotics that are sedating in nature to help these individuals. So, acute treatment of episodes of illness aims to resolve symptoms, reduce immediate risk to self or others. And that's why we are talking about the antipsychotics. But the long-term treatment is aiming to prevent future episodes of illness and help regain a pre-morbid level of functioning, improve physical health, and reduce long-term suicide risk. And this is what, in the long run, we want to achieve with our patients. We know that many patients with bipolar disorder will resent treatment because they actually do enjoy the mania or the hypomania. They're able to achieve so much in it. They consider it to be a gift from God sometimes, and they don't want you to interfere with that. And when you treat them, sometimes they tell you, you have taken something away from me. I'm not myself. You've altered my personality. But we want to be able to appeal to the long-term aim that you will not get future episodes of mania or hypomania or depression, and that you can regain your pre-morbid level of functioning. We can prevent or reduce the long-term risk of suicide. Patients cycling between mania or hypomania and depression are difficult to treat, and stabilizing mood is as important as treating. So I do also sometimes come across requests by patients who will say, well, doctor, um, I, I, I have taken these medications for so long. Is it possible we could start reducing it? Do you think I can go off it? And I'm thinking to myself, we've been on this journey for the last 1 year through a trial and error process, trying to find just what is the exact or what is the combination that works in terms of dosages and combinations of other medications. And here you are wanting to interfere with that, yet we've enjoyed such stability. And so achieving that is not a one-day process. It's not as simple as saying lithium carbonate 800 milligrams at night. It's not an exact science. We have to keep on working with these patients. And so when patients come and they want to reduce their medications, I don't know, but for my own experience, I am always a bit worried, especially when we've reached a sort of working dosage and that the mood has been stabilized. We do also believe that the mainstay of treatment for bipolar 1 and bipolar 2 is really medication. Medications that we refer to as mood stabilizers. But there are also many individuals who come across, and when you chat with them, they do seem to fit the criteria, especially for bipolar 2 mood disorder. And you wonder how they've survived for so long. They are high functioning. They're doing very well in their careers. And so you keep asking yourself, do I really need to medicate this person? What if I medicate them and their careers start to plummet? And because it's episodic, it's quite conceivable an individual can stay well for an extended period of time. But we must agree that medications will be the mainstay of treatment for both bipolar 1 and bipolar 2 disorder. Psychotherapies are important in reducing relapses. You utilize them to psychoeducate, to deal with irrational thoughts, and we shall look at some of the psychotherapies that are deployed. Having a strong therapeutic alliance with your patient, and a therapeutic alliance means that you have an unconditional acceptance of your patient, and you are always available and open and in a non-judgmental manner interacting, and the patient can take you into their confidence and feel that they can talk to you about their most, even the most mundane of things. Maintaining the continuity of care, like I mentioned earlier, despite the fact that the illness is episodic, we do not know when the next episode will come. And so it's important to have continuity of care. The presence of comorbid conditions, disorders, the one that comes to mind immediately is attention deficit hyperactivity disorder. The use of psychostimulants, sometimes associated with episodes of mania or hypomania, and therefore risk of relapse. The use of alcohol, if a person has comorbid alcohol use disorder, and other substances, cocaine, heroin, etc., etc. If a person has a sleep disorder that disrupts their circadian rhythms. I mentioned about the role of psychotherapy. CBT helps to identify and tackle harmful thought patterns and behaviors. Family-focused therapy to improve family communication patterns, strengthen problem solving and coping strategies. remember the teaching about expressed emotion in families, and us being able to assist family members to be not as involved, enmeshed, I think is the word, in the management and the support that they can provide to their significant others who may be unwell. Interpersonal and social rhythm therapy deals with problems with the relationships and daily routines. I think the clinical psychologist in the room relate to that very well. Psychoeducation, I don't think that I need cognitive remediation, behavior training to improve cognitive performance, benefits people with bipolar disorder, as well as those with schizophrenia. I think the incorporation of individuals with skills in occupational therapy and other psychotherapies comes into mind when we are thinking about this. This is a treatment algorithm for bipolar type 1. Sorry, I apologize for the small print. But the first step is assumed will be to evaluate the efficacy of acute treatment and consider predominantly polarity. Consider predominant polarity. Are we predominantly depressed or predominantly manic or hypomanic? And then to check adherence. And to do so, we then initiate or optimize first-line monotherapy. And you can see there that lithium or quetiapine are right in the middle. In other words, it's a very balanced sort of mood stabilizer. They are more or less like the gold standard that help prevent depression and help to prevent mania. But if you go for aripiprazole in the place of quetiapine, you're more likely to be preventing mania. And every 6 months then, you'll be assessing efficacy, the presence of subsyndromal symptoms, side effects and tolerability, functioning and quality of life are sort of like the key things that you're looking for in your evaluation process. And so you will combine first-line options. So the first-line options, lithium plus quetiapine. Yeah, if these things are fallen off, that the patient has, you feel that your medication is not as efficacious as it should be as a monotherapy, yeah, or you have subsyndrome or some breakthrough symptoms as sometimes they are referred to, or even side effect profiles. Combining can help you reduce the dosages and still achieve the proper efficacy that you are looking for. So combining first-line options, either combine lithium with quetiapine or with aripiprazole. And if you want to then prevent depression, then lamotrigine might be more preferred one. Or if you want to prevent mania, either aripiprazole or paliperidone might be. But the valproate or olanzapine, asenapine would probably be the drugs of choice as alternatives to the first lines. Then step 2. Sorry.
Tom.
Oh, sure.
Tom Nyangwara, please mute.
So step 2, which you are assessing every 6 months, the same parameters. If you want to then go to second line options, if the first line options and their combinations are not working, These are the second line combinations that you could consider. If you want to prevent depression, lamotrigine combined with valproate or lithium, or olanzapine plus fluoxetine, which is a preparation that comes as in one form. I don't think it's locally available. Lamotrigine plus quetiapine or lurasidone or olanzapine or aripiprazole for the prevention of depression. Lamotrigine is key. If it is mania, then it's lithium or valproate combined with ciprasidone, risperidone long-acting. Or if you want just a mood stabilization between depression and mania, then you're looking at either combining lithium and valproate, which we've seen earlier, lithium or valproate plus those other ones, olanzapine, amisulpiride, gabapentin, or valproate and aripiprazole. But you'll see that they all seem to be recurring. And if you are to rate them, then you are looking at lithium, quetiapine, valproate, and then now you come to your atypical antipsychotic agents. At the end of 1 year, again, the same parameters are used to evaluate efficacy, subsyndromal side effects, tolerability, functionality, and quality of life. And if there's resistance to treatment, you might want to switch to combined effective treatments and so on. These are the drugs approved by the Food and Drug Administration for management of bipolar disorder. And you can see that basically the gold standard is lithium for both mania or mixed episodes, but not for depression. For maintenance treatment, yes. And note a very, very that are now practicing polypharmacy and throw in lithium, even where it doesn't seem like the patient a bipolar disorder. But there's a price, hypothyroidism, I'm so sorry. Sorry, my internet dropped off a little. So I was mentioning that hypothyroidism, either you get just a hypothyroidism or even you can end up with a goiter, but it is believed that at least the hypothyroidism can be reversed by withdrawing the lithium. Carbamazepine, divalproex, and lamotrigine. These are the anticonvulsants that are FDA approved, but some people will say that off-label, you can also use topiramate and neuron and gabapentin. This is the list of the antipsychotic agents, and basically it has all the second generation or atypical antipsychotic agents. Note the presence of our old friend chlorpromazine, but we don't talk a lot about first generation antipsychotic agents as having mood stabilizing properties. But indeed, there are studies that seem to indicate that they too can and do provide mood stabilization. And in our under-resourced environment, it's quite a viable option when we can't afford or find the atypical antipsychotics, which tend to be fairly expensive. These are the historical milestones I think I mentioned earlier for lithium, that John Cade, 1949, 1954, Stromgren from Denmark, who replicated the findings of John Cade. Shu, who not only did so, but pursued lithium to contribute in establishing its safety and effectiveness. And note that the FDA approved lithium in 1970 for acute mania, and in 74, the only approved treatment for the prevention of recurrences in bipolar disorder. Lithium today, I mentioned earlier, remains the gold standard for treatments of treatment for preventing recurrence in bipolar disorder, both types. It has evidence now for preventing suicidal behavior. It has lately been not as frequently prescribed, especially in the US, mainly because of the rigorous monitoring required of serum levels, the therapeutic window of 0.6 to 1.2 millimoles per liter, the development of thyroid complications, renal complications, and then, of course, the number of litigations that are rising out of medical practice make it very difficult in the US and the more modern or the more advanced countries to use this particular medication. But I must state that even in Kenya now, litigation is starting to be a big deal. Lithium has been said to have neuroprotective properties and also neuroproliferative effects, preservation of gray matter. The mechanisms are not known, and clinical implications are not clear, but could clearly be that this is how some of these effects of lithium are achieved. How efficacious is lithium? It's effective in treating acute manic episodes, but it cannot on its own be used. And I think I mentioned earlier that the use of sedating antipsychotic agents becomes quite a mainstay in the initial treatment for a person with acute mania. Greater benefit against recurrences of mania than for bipolar depression. Satisfactory mood stabilization over 6 to 12 months can be attained by about 2/3 of lithium-treated bipolar patients. And an excellent response has been found in 1/3 of such patients, i.e. a rate of 33% of no episodes, no recurrences, no relapses in a 3-year period. The long-term risk of new manic or depressive episodes lower with lithium than with placebo, and we saw the figure, 35% versus 80%. In acute mania, the evidence for lithium monotherapy is overwhelming, and hence its primacy in clinical practice guidelines. But like I stated earlier, it does eventually work, but there is need to assist these patients along, because then if they're not in an environment where they can be confined, it can be quite a handful. But eventually, like we say, the gold standard is lithium. I think the second point is very well taken care of. Because the effects of lithium in the treatment of manic episodes may take 6 to 10 days after initiation, and I think that's the same point. Okay. In depression, acute depression, the evidence is not as overwhelming in managing episodes of depression, even in patients with bipolar disorder, and it's therefore not considered a first choice as monotherapy. Its value, like I said earlier, is more in preventing suicides. Yeah, that's the point being made there. I want to skip that slide. For prophylaxis, a significant decrease in risk of relapse along with the prevention of suicidal behaviors. And then there's a study there that seems to demonstrate that. It's particularly potent in reducing manic recurrences of manic episodes, and that benefit does not extend to depression. Dysthymia and cyclothymia. Low dose for cyclothymia. Significant preventive effect on depressive episodes in 26 to 36% of cyclothymic patients over 2 years. Again, prophylactic really, rather than for the management. The clinical implications, the treatment and prophylaxis of mania, manic depressive illness, recurrent depression, and the treatment of aggressive or self-mutilating behavior. These are really the indications. So if you like, side effects and contraindications. When lithium is initiated or increased markedly, then you can expect gastrointestinal upsets. Many a patient will tell you, I do not seem to taste the food anymore. I need to add a little more salt. I need to spicy up my food a little bit. I seem to be flatulent, more gas. Tremor, they have this called tremor that seems to extend even beyond the discontinuation of the lithium, and it is said that the use of a beta blocker can help with that. Polydipsia, excessive fast, polyuria seems to have a diuretic effect, as would be expected since it's an alkaline salt. Headache, an alkaline metal. Headache and fatigue, transient and usually in the initial period of treatment. Long-term treatment of lithium can impact the renal system. Less common but high burden, and I do have cases of patients who have had to take off lithium because then their renal function tests started to drop off. And so when you are starting lithium, it is very, very important to educate the patient and let them know that although it's a gold standard, it also has its own implications in terms of side effect profiles, long-term side effects. Thyroid, like I mentioned earlier, may be reversible upon discontinuation of the lithium. Parathyroid functioning, it's not such a big deal. Moderately common, but also not so. Weight, I think the weight gain has been approximated to be about 5 kg on average. That when you put individuals on lithium, they gradually gain and they stabilize, but they'll probably end up with a 5 kilogram weight increase. Toxicity, yes, toxicity, tremor, delirium, confusion, coma, seizures, and sometimes death. It's sort of progression. And there they put an adverse reaction to high concentration, 91.2 millimoles per liter. That would have to be someone who has taken a huge overdose and will go into acute intoxication and some of the complications I've just mentioned acutely. Chronic toxicity, mainly the renal complications, the thyroid complications, and to know that hemodialysis can be used to counter some of those effects. In the unborn child, the Epstein malformation, which is really heart defects in the fetus, especially when used in the first trimester of pregnancy. So if your patient discovers they are pregnant, you must discontinue the lithium immediately, and you must continue to have that baby monitored intrauterine even through obstetric ultrasounds and things like that, just to be sure what is happening to their hearts. Effects through transfer in breast milk are known. The patients who become pregnant while breastfeeding, again, like I say, from the onset, you must psychoeducate these individuals and let them know about the risks and let them then choose and commit to this commit to let you off legally if anything happens to them or to the unborn baby. Older patients, higher risk of toxicity due to age-related renal changes. That is fairly obvious. Patients with existing kidney problems, again, may not be suitable for and could worsen their conditions. These are some of the more common side effects that patients complain of. Excessive thirst, polydipsia, polyuria, memory, tremor, weight gain, drowsiness and tiredness. I think more of tiredness than drowsiness, diarrhea. Well, as happens sometimes, for as long as you're introducing a new medication, people will complain of something or the other. Lithium has a therapeutic window, and that therapeutic window has been described as between 0.6 millimoles and 1.2 millimoles per liter. Below that, it's said not to be very useful, and relapse and recurrence will occur below 0.6 millimoles per liter. And above 1.2, we are headed the toxicity way. Suicidality, I think I will not burden you with this. I think we've mentioned it quite a number of times. Risk factors of suicide, these are well known throughout. Anybody who is in mental health will know about evaluation of suicide risk. Warnings and side effects, I think we've covered that. These are the special populations. Pregnancy, we've mentioned first trimester, breastfeeding mothers, unless benefits of lithium outweigh the disadvantages. Children are not really candidates for the use of lithium. This is my final slide. A lot of the information we have there is drawn from this paper by this individual. I thank you all. Thank you.
Thank you very much, Dr. Kigamwa. That was very informative, very insightful. Thank you very much. We are at our Q&A session. So if anyone has a question, feel free to ask. Any question? You can put it on the chat. Or you can unmute and ask.
Hello.
Dr.
Hello.
Yes, Dr.
Dr. Yes. It's one thing that nobody knows exactly, and Dr. Kigamwa hasn't talked about, is mechanism of action of lithium. Mechanism of action of lithium. It's their proposed mechanisms, but nothing is exactly specific, but is thought to eventually work on neurotransmitter systems and eventually reduce excitatory glutamate excitation and increase inhibitory GABA transmission. The other thing I have noticed is the first side effect of lithium that you'll see are tremors. Usually they are fine tremors. If you see a patient on lithium and they come with tremors, that sometimes you may have to elicit yourself. The patient may not exactly report that, but you may have to elicit yourself. I elicit by asking the patient to stretch out their arms, and then you put a sheet of paper on top of their hands, and then you are able to see that fine tremor. So when you see that fine tremor, if you send for lithium levels, you're going to see that they are raised or marginally raised. And on top of the other addition that I wanted to say is that the therapeutic range is 0.6 to 1.2. When you see toxicity seen up to 1.5 and up to 2.5 is almost fatal. Anything above 2.5 millimoles per liter would be fatal. The other observation I made is that quetiapine actually works on all phases of bipolar. Most other drugs just works on one phase or two, but quetiapine works on all phases. I guess that's why I said it's first line of treatment. Thank you. That's my contribution.
Asante sana, Dr. Onyango. Thank you very much. Dr. Francisca says, thanks, Dr. Kigamwa, for that detailed presentation. Dr. Araka says, brilliant presentation, Dr. Kigamwa. Professor Mudhoni Madhai is saying, indeed, excellent and very informative. And she's asking if we can get the slides. I hope we can avail that, can avail the slides. Dr. Araka is also asking, how would you prescribe lithium to a patient with a depressive Dr. Araka's question, how would you prescribe lithium to a patient?
All the fences were very sturdy.
Dr. Elizabeth Imudu. Elizabeth, thank you.
Yes.
Just mute, thanks. Dr. Raka's question, how would you prescribe lithium to a patient with a depressive episode with suicidal ideation? Dr. Kigamwa.
Thank you very much for all those kind messages. I think there's the mainstay of treatment of depression is obviously antidepressants. But remember, when we are talking about treatment-resistant depression, one of the augmentation strategies is to use lithium. Lithium on its own, as far as we've seen and heard, is not as effective for treating depression. But in augmentation strategy and in managing suicidality, not on its own, not as monotherapy, but with an antidepressant. Thank you.
Thank you, Dr. Kigamwa. Dr. Juliet says, thank you so much, Dr. Kigamwa, for a comprehensive presentation. Dr. Sylvia, excellent presentation, Dr. Kigamwa. Dr. Mohammed says, thank you, Doc. Please comment on the use of immediate release or sustained release formulations versus the severity of the side effects. Dr. Kigamwa.
Thank you for those comments again. I think the main advantage of the slow release is the avoidance of multiple dosing that we see with the plain lithium carbonate. But also in terms of peak levels, when you take the plain lithium, the rate at which it's absorbed, and you remember lithium is excreted unchanged, so there's no fast pass metabolism through the liver. And so the moment it hits the gut, it's absorbed and will peak when it's a plain. And so in terms of side effects, initially then the usual acute side effects, the nausea, the metallic taste, and so on, are more pronounced when you are dealing with the plain than with the SR, the slow release version. Thank you.
Thank you, Dr. Kigamwa. Moses Mwenda says, thanks Mwalimu for enlightening presentation. Comment on recent use of low-dose lithium by some clinicians despite narrow therapeutic window of 0.6 to 1.2 milliequivalents per liter.
Yes, so I think the slide which was showing the therapeutic window did indicate that lithium levels below 0.6 are associated with the relapse of either mania or depression in a person with bipolar disorder. However, when you're having to deal with lithium to help prevent suicide, you could actually combine it with other mood stabilizers or antidepressants at a much lower level, and it still confer a benefit as far as suicidality is concerned. But as far as mood stabilization is concerned, outside of the therapeutic window, we probably are not doing anything.
Right, thank you. Dr. Catherine Mutisia says, excellent presentation. Dr. Catherine Gitao says, thank you for the great presentation. And her question is, what is your experience with lithium orotate?
I Again, thank you. I have no experience with the lithium orotate. I don't think it's locally available. But I've seen comments to the effect that it's probably has a better side effect profile.
Right. Dr. Araka says, coffee or caffeinated drinks or nuts, should they be avoided completely or restricted during lithium treatment, especially if there's delayed achievement of therapeutic level?
Well, coffee, if you are asking about coffee, just the same way I said earlier that psychostimulants can be associated with the onset of relapse and episodes of especially mania, hypomania, then using the same reasoning, one would say that probably should be avoided. Nuts, I am not sure the relationship between nuts and lithium treatment. Maybe I'm not able to comment. Anyway, anyone can comment on that, please.
Dr. Araka, would you mind unmuting and saying your experience with nuts?
Yes. The nuts are caffeinated nuts, not just because food stuff comes packaged in different ways. So you've answered the question, Dr. Kigamwa. Thank you very much.
All right. Thank you, Dr. Araka. Dr. Stephen Onyango says, in our setup, we only have lithium carbonate. In the Western world, they have lithium orotate that has lesser side effects. Okay. Dr. Edwin Mokwa says, excellent presentation, Dr. Kigamwa, very informative indeed. Dr. Leonard Njeru says, thank you, Dr. Kigamwa, for an enlightening presentation. Please clarify on how to wean off a patient off lithium in case of side effects, if there is any recommended antidote, and the alternative medication to replace lithium.
Thank you for that excellent question. Generally speaking, there is no withdrawal schedule for lithium. I think what you would then do if a patient has a toxicity is immediately withdraw the lithium, replace it with one of the other mood stabilizers. And if we are in the toxic ranges, then dialysis is what has been recommended.
All right. Thank you, Dr. Kigamwa. Any other question? Anyone would like to unmute and ask a question? All right. Okay. So we will have Sun Pharma do their presentation. In case there are any more questions, please feel free to put them in the chat and we shall ask them whether they are to Dr. Kigamwa or to Sun Pharma. So at this point, I welcome John from Sun Pharma to do their presentation on lithium. Thank you. Before John starts, kindly allow me to read Dr. Nderi's comment. Lithium should be reduced gradually over at least 4 weeks and preferably up to 3 months. Thank you, Dr. Nderi. Maybe as John continues getting ready, Dr. Nderi has also said in case of abrupt discontinuation, observe closely for recurrence of mania or depression. Dr. Onyango has said, I think that antidepressants can be used in bipolar depression, but must be titrated to only the time of acute depression and must be stopped once the patient is out of it. Thank you for those comments. Dr. Raka has one more question. Dr. Raka, you can unmute and ask.
Okay, so Dr. Kigamwa, I had a patient who was put on lithium a few years ago, let's say 3 years, but was not compliant. But now, because the symptoms are bothering him, he would like to be put on the lithium. Would that be a good idea, or would you rather consider another mood stabilizer? What would be a better choice?
Sorry, thank you for that. You are asking if it would be a good idea to put someone back on lithium who had discontinued it.
Yes, yes.
Yeah, I mean, lithium remains. What was the reason for discontinuation?
Just non-compliance, multiple substance use disorders.
Yeah, well, it still remains the gold standard. The fact that you've been on it in the past and discontinued it, it should still be considered. However, I think the bigger challenge would be to first deal with the substance abuse, because then you are unlikely to manage the mood disorder for as long as there's substance involved. But I would consider putting them back on it if the substance use is managed. I don't know if I got the question right, but
yes,
that's...
my concern is what if he's non-compliant again when we put him back on the lithium?
Yeah, so
I think that's why I was wondering.
Yeah. But like I say, your challenge is really the substance. Because as long as the substance is in the picture, then compliance becomes a big deal. Unless we are now starting to think, let's do depot preparations. And even then, getting the individual to comply even to the depot could be a challenge in its own.
Yeah.
But yes, yeah, I would still give him the benefit of lithium. The other thing is, of course, because of the nature of the monitoring that you need to do with lithium, you might not want to give somebody who is substance dependent a drug like that, because there's no knowing how they'll manage it. Yeah.
Yeah. Okay. Thank you.
Thank you for that discussion. Dr. Nderi also says the monitoring of relapse should go on at least for 3 months. Thank you. John, are you ready?
Hello. You can hear me?
Yes, Rawlings, we can hear you. Or is it John?
That is John. Sorry for the minor delay. Yeah, so my name is John Mutungi. I'm working for Zen Pharma. I'm the first line manager for the CNS division. I'm going to be taking you through some of our brands we have in the Kenyan market. I'd like to start with the profile of my organization. Sun Pharma, we have been in Kenyan market for the last 3 decades. We came in Kenya in 1993, whereby we have been reaching our patient and touching their lives through a wide range of both neuropsychiatric and other range of products which we have in the Kenyan market. So going the topic of today, lithium, as Dr. Kigamwa has mentioned, remains the gold standard for the treatment of bipolar disorder, both bipolar 1 and bipolar 2. And also there's sufficient evidence to show that lithium is able to prevent suicidal ideation in those patients with bipolar and also major depressive disorders. Lithium normally works in 3 major ways. First, lithium has a positive modulation of GABA receptors. And we all know that GABA is an inhibitory neurotransmitter. Lithium has a negative modulation of glutamate receptor, which we know glutamate is excitatory neurotransmitters. And also lithium has a negative modulation of dopamine receptors. This is just a repetition of what Dr. Kigamwa has presented. The therapeutic plasma concentration of lithium. Major guidelines normally recommend that the initial treatment for bipolar disorder is supposed to be 0.6 to 0.8. And for the depressive disorders, major guidelines recommend levels of 0.4 to 0.8 millimeters per liter. For acute mania, greater levels of 0.6 to 1 or 1.2 millimeters per liter are indicated as sufficient for patients. And all these lithium levels must be the competing patient concern has to be factored in, like the weight of the patient, probably the cardio parameters of the patient, the renal parameters of the patient must all put into consideration before we put our patient on lithium. Going for dose and administration, major guidelines recommend a dosage of 400 to 1200 milligrams, even in either it's a single dose during the morning or during the evening. Alternatively, the dose can be divided into two. It can be given during the morning hours and also can be given during the evening. The first week after we initiate lithium treatment, we are supposed to take the lithium serum levels to so that we can be convinced whether they have reached the level whereby we are the toxicity of the patient can be able to be managed or how to be during that time. The blood sample should be taken 12 to 24 hours after the previous dose of lithium has been given to the patient. The serum lithium level is not supposed to go beyond 1.5 millimoles per liter. That's going to be toxic level to patients. And when we're coming off the lithium carbonate, the nice guidelines recommend a gradual reduction in lithium carbonate for at least the 4 weeks. And the maintenance dosage for lithium carbonate is 900 to 1200 milligrams in a day. I won't be able to talk about the warnings because the many presenters talked about the warnings. Special populations, special consideration has to be taken into consideration, actually for the pregnant populations. As you know that lithium is able to cause congenital heart defects. So during the first trimester, you have to be careful when or not to give the lithium carbonate. For nursing mothers, lithium is easily expressed in the breast milk. And the benefits of the lithium have to be put into consideration before we put lithium to nursing mothers. Up to now, we don't have any convincing studies to show that lithium can be used in children or in children. So for that population, we also have to be careful when we are dealing with children. Side effects, Mr. Kigamwa has talked about it, so I won't be able to talk about them. So going into the major recommendation, that's the Canadian Network of Mood and Anxiety Treatment of 2018 and also International Society of Bipolar Mood Disorders. Lithium, in terms of hierarchy, lithium comes first compared to other molecules. We have lithium, we have quetiapine, we have divalproex, we have xanapine, we have piprazole. But based on the Canadian and International Society of Bipolar Mood Disorders recommendation of 2018, lithium comes on top when it comes to the management of acute mania. It has a level 1 evidence for acute mania. It has level 1 evidence for the prevention of any mood episode. It has level 1 evidence for prevention of mania, and for the prevention of depression, it has level 1 evidence. For the maintenance of acute depression, it has level 2 evidence. Compared to quetiapine has a level 1 evidence for the treatment of acute mania. It has for the maintenance phase, it has a level 1 evidence for the prevention of any mood episode. For prevention of mania, quetiapine has a level 1 evidence, and for prevention of depression, quetiapine has a level 1 evidence. Also, the same guideline of 2018, that's the Canadian Network of Mood and Anxiety Disorders. When it comes to the maintenance treatment of bipolar 2 disorders, the first line agents are 3 according to Canadian of 2018. That's quetiapine, it has level 1 evidence. We have lithium and we have lamotrigine. Both lithium and lamotrigine are level 2 evidences. The second line agents for the treatment and maintenance of bipolar 2 disorder, we have venlafaxine, the level 2 evidence. We also have third line agents such as carbamazepine, divalproex, escitalopram, fluoxetine, and risperidone, among other agents. Still on Canadian guideline of 2018, when it comes to the ranking of the first and second line treatment for management of acute bipolar 1 depression, the first line agents we have, according to that guideline of 2018, we have the quetiapine. Quetiapine as level 1 evidence for acute depression. Quetiapine has level 1 evidence for prevention of a head mood episode. And the quetiapine has a level 1 evidence for prevention of depression. And for the depression of mania and acute mania, quetiapine still has a level 1 evidence. Based on that, the ranking for the treatment and the management of acute bipolar 1 depression, lithium comes number 3, quetiapine is number 1, followed by combination of racidone with lithium and divalproate. Then lithium is number 3, lamotrigine number 4, racidone number 5. Then the second line agents, we have divalproate, among other agents. So coming to pharmacokinetics of lithium carbonate, we all know that lithium carbonate is excreted through the kidney, and it has a half-life of 18 to 36 hours. So now jumping into my brand, which is lithosanessar. In the management of bipolar disorder, prescribed lithosanessar. Lithosanessar will be able to stabilize the mood of your patient, and lithosanessar is going to improve compliance. Lithosanessar is the first line of option for the treatment of acute mania, and lithosanessar is the add-on of choice for those patients with acute depression. Compared to most of the anticonvulsant, lithium SR is superior to most anticonvulsant when it comes to the maintenance phase of bipolar disorder. So that's a photo of our lithium SR, lithosanessar. It comes in a strength of 400 mg, available in the Kenyan market. And the advantage of the controlled release formulation is compared to the initial instant formulation in Kenyan market. This one is going to improve the compliance because as you have seen earlier, you can give it a holding during the morning or the evening. And also in terms of side effects, controlled formulation, slow release formulation have minimal side effects compared to instant release formulations. Apart from lithosanessar, which is our lithium carbonate 400 mg, we also have a big basket for both neuropsychiatric products. We also have our zolpidem 10 mg, going by the brand name of Nitress, which is available in Kenyan market. Our fluoxetine 20 mg is called Podep, available also in Kenyan market. Our brand of sertraline is called Zosat 50 mg for those patients with postpartum depression and also premenstrual sporic disorder. Sertraline is also at 50 mg. It's a first line agent for such conditions. Our risperidone is Sizodone. We have 2 mg and 3 mg available in Kenyan market. Our brand for escitalopram, we have Nexito, we have 10 mg and 20 mg. As we know, Nexito or escitalopram is the most potent SSRI, especially for those patients with the major depressive disorders. Also, we have mirtazapine in the Kenyan market, going by the brand name of Meters. We have 15 mg and 30 mg. So for those patients who are not able to sleep, those patients who are not able to feed, and also those patients who are cautious about their sexual life, Meters is the antidepressant with the minimal chances of interfering with sexual function of your patients. Also, we have our anticonvulsant in the name of Encrate Chrono. We have a plain salt of 200 mg. We also have Encrate Chrono, that's combination of phosphoric acid and sodium valproate. That's 300 mg and 500 mg. We also have our Nduzela, which is our duloxetine, and Nduzela is balanced SNRI. For those patients who have depression and somatic pain, Nduzela is a brand of choice. We have 20 mg, 30 mg, and 60 mg in Kenyan market. We also have another anticonvulsant called Levipil. Is for onset seizures, refractory seizures, and also idiopathic seizures. We have 250, 500, and 750 mg in the Kenyan market. For those patients who are not able to respond to SSRIs, we have an SNRI called Venice XR. We have at 7.5. We also have 75 mg in Kenyan market. Our olanzapine, our brand of olanzapine is Holians. We have 5 mg and 10 mg. Finally, our brand of quetiapine is quetiapine, 50 mg, 100 mg, and 50 mg, 100, 200, and 300 mg. So we have the four formulation, the four strength Kenyan market. And quetiapine, as we know, is the first line agent for the treatment of bipolar mood disorders. As it has been demonstrated by many guidelines such as Canadian Network of Mood and Anxiety Disorder of 2018, and also NICE guidelines. So those are my brands, and is my my prayer to you guys, to you doctors, whenever you come across patient who serve this brand of ours. As I've said, we have been available in Kenyan market for the last 30 years. We have been strong. We have been reaching our patients. We have been touching their lives through this big basket of neuropsychiatric products. So those patients who just want to serve any of these brands of ours, kindly don't hesitate to pass the benefits of our product to your patient. So I think that's all for me, unless there's any question from any doctor. Thank you.
Thank you very much, John. That was also very insightful. Thank you very much. Dr. Kingi Mochache says, great presentation, Mwalimu Dr. Kigamwa. She says, just to say, lithium is a very effective and good drug, not as scary as it appeared in medical school. Monitoring of therapeutic ranges is also easily available in Nairobi and affordable at less than 2,000 per test. If the diagnosis is right and with compliance, it works quite well, and toxicity can be detected very early from clinical features before even labs. Thank you, Daktari. Dr. Wekesa is asking for CPD points. Dr. David Wairoto is asking, thanks, Mwalimu, for a wonderful presentation. His question is to Sun Pharma. Are you considering bringing depot preparations to Kenya market? John, please. John or Rawlings?
Yeah, I'm here.
Are you considering bringing depot preparation to the Kenyan market?
Right now, we don't have plans for the depot, but going forward, because in the recent time we've been able to bring to Kenyan markets other formulations, I believe because based on the inquiries we are getting, we might consider bringing those formulation in Kenyan market. But for now, we don't have any plans for now.
All right. Dr. David Wairoto, we need options for medications such as depot for aripiprazole and risperidone. Kindly note Rawlings and John. Dr. Samuel Kamoche is saying quetiapine is first line, lithium is gold standard. It is confusing. Dr. Kigamwa, please.
Thank you, Dr. Kamoche. In an ideal world, you use the gold standard. In a less than ideal world where you cannot do all the monitoring, your first line is quetiapine. You'll note that I said you can either, as first line, do lithium or quetiapine. Thank you.
Thank you, Dr. Kigamwa. Any more questions? Anyone would like to unmute and ask a question? All right. Oh, okay. David?
So sorry, it was by mistake, sorry.
All right, that's fine. So I'd like to thank all of you for attending this this webinar. Special thanks to Dr. Kigamwa for the excellent presentation. We have learned a lot. Thank you, Sun Pharma, for sponsoring this, and thank you, KPA, for sponsoring this. Any comments from KPA? All right. Okay, so we can call it a night. I wish you all a great night.